Yes.
Okay. So let's get started. So I'll spend a little bit of time talking about what FFRCT is and how it helps us in clinical practice. But then most of the time I'll spend on some of the things that might be relevant to you guys when we implement FFRCT there, like protocols and what we do with the results, how do we get them, how do we send the request and stuff like that. So what is FFRCT? So it stands for CT derived fractional flow reserve. And it is obtained from coronary CT datasets. It is acquired through computational flow dynamics and machine learning. And it uses that CT dataset to predict if a stenosis is flow limiting or not flow limiting. The concept comes from FFR in the cath lab, in which during an angiogram, a stenosis is seen, let's say a 70% stenosis, 60% stenosis, but we don't know if it's flow limiting. All we know is that the diameter shows us 70% stenosis. And in the cath lab, what you do is you use a wire, a pressure wire, to measure the pressure inside the coronary artery distal to the stenosis, and then you compare that pressure with the pressure in the aorta. And that pressure ratio is the fractional flow reserve. Now in the CT data, we're not using a wire, and hence we're obtaining it from the CT images, and we're using the concept of fluid dynamics. Once the patient has the CT done, there's no additional testing, there's no additional radiation, there's no additional medications, but there is a cost. There's a cost to the test, and the steps, kind of very abbreviated, that go into obtaining FFRCT is, so you start with that 3D data sets from the coronary CT. Those images, those DICOM images, are then sent to the company, which is HeartFlow. HeartFlow is the only company right now that is FDA approved to do the test, and also reimbursed by insurances and by Medicare. There are other companies that are working on developing a product, but HeartFlow is the only one that is available commercially to be used. So we send the image to them. They then, from those CT data sets, obtain the mass of the myocardium, which is the mass of the left ventricle, and also the volume of the coronary arteries. So the volume of the three main arteries, but also all of the small arterioles as well. They use equations, which these equations are similar across all species, and some of these equations govern how much our myocardium needs blood flow at rest, and that's kind of standard against most species. Based on some of this information, they use this complicated sort of equation. These are the computational fluid dynamics equation that are not just used in medicine, but are also used in engineering, aerospace, car racing, many different other fields. And then the end product is what you see here. So you're looking at the aortic root, the three coronary arteries, the RCA, LAD, circumflex, and at multiple levels here, you can click to obtain that FFR value, which again is the ratio of the pressure in a specific area of the coronary artery compared to the pressure in the aorta. So some of the applications that we use FFRCT for, so we know from patients that undergo non-invasive stress testing and that then end up to the cath lab, even among patients who have a positive stress test, so this is a positive stress nuclear, stress echo, stress PET, when they go to the cath lab, about 50% have obstructive disease and 50% don't have obstructive disease. By obstructive disease, what we mean is needing a stent. So about 50% of the patients that have a positive stress test essentially don't need to go to the cath lab. So the current method of using stress test is not very good at selecting patients that need to be in the cath lab, that need an intervention. Because the idea is you go to the cath lab if you need to get a stent, but if you don't need a stent, then you don't need the invasive procedure. So a couple of years ago, there was this trial that was done from Duke, something called the platform trial, and they randomized about 190 patients in each arm. These were patients that had already been selected to go to the cath lab based on clinical information, based on other stress testing. So these 390 patients were going to go to the cath lab. And they divided the group, they randomized the group into two groups. The top here, they said these 190, we'll just send them straight to the cath lab. But these 193, before they go to the cath lab, we're going to do a CT, we're going to do FFRct, and then only if that shows something, you'll go to the cath lab. So when you compare the two groups here, the FFRct group versus the usual care group, the rate of caths showing non-obstructive disease, meaning that no intervention was done because they didn't need a stent, went from 73% down to like 13% in the patients that have FFR. So out of the patients that had FFR, there was a 60% reduction essentially in diagnostic caths. And 60% of the caths got eliminated because the CT was more specific, especially combined with FFR, in keeping these patients out of the cath lab. And then when you compare the cost, the blue line is the FFR cost versus the gray line is the patient that went to the cath lab. So even when paying for FFR, it still costs less money to get a CT and to do the FFR rather than to send the patients to the cath lab. And that cost continued all the way out to a year. And then when we look at 117 patients that had their caths canceled out of 193, their MACE rate at 1 year was essentially 0. So MACE means any kind of adverse effect. If the patient had an MI, heart failure, hospitalizations, this is what's considered MACE. So we canceled this, but they did well. Essentially, they didn't have any bad outcome because their cath was canceled. This was a large registry, something called the Advanced Registry that includes about 5,000 patients, which we at Beaumont were part of, and followed patients for 3 years, essentially, and it divides them into positive FFRct versus negative FFRct. So FFRct less than 0.8, that ratio, that's considered positive. And if you're greater than 0.8, that's considered negative. So their event rate, their outcome, again, much lower in the patients that had a negative FFRct, and the revascularization, meaning stents, bypass, again, FFRct of greater than 0.8, much lower than the ones that were positive. Now, there was a study that was done in Europe a couple of years ago that included about 200 patients, and these patients underwent CT, a PET, SPECT, cath, and invasive FFR. And there was one thought around that time was, well, if we do a CT has very, very high sensitivity, but the specificity is not that high because you see these calcified plaques and you don't know if that's a true stenosis or if that's just blooming from calcium. So they said, well, if we do a CT and we do an MPI, a stress test, that's going to be great because we're not going to miss anything, and then the PET, the SPECT is going to be specific. Well, in the trial, it didn't really work out that way. When you combine the CT and the PET, essentially you got a mediocre, you got an average result of both of them. So you weren't as specific. So that's kind of what this trial shows. But these patients also underwent FFRct, and then they compared what's the best accuracy. So they used, here's the SPECT line, here's the CTA in red, here's the PET in green, and this is the combination of CTA and FFRct. So that really showed the best accuracy. So here's an example, one of our patients. Now, how can FFRct kind of help in the cath lab? Here's the LED from a CT, proximal LED, so you see there's a severe stenosis. And this is me measuring on the CT kind of what the diameter of this vessel is. And here at the beginning of the plaque, the diameter was about 4.5. At the end of the lesion, there's about 3.5. And this lesion measured about 30 millimeters by hand. And here's the FFRct for that same patient. And again, you see there's the left main LED circumflex here. And you see that the FFR essentially becomes red and 0.69 here in the prox LED, so it's positive. So based on this, we were trying to come up with the sizing of the stent to use during the intervention. So I told the interventionalist, okay, most likely you're gonna need a stent which is about 30 millimeters long, which is about 3.5 millimeters in diameter. Here's the cath of that patient. There's the LED up here. So severe stenosis, and this is after the stent was done. So this patient got a stent, and the stent was 3.5. It was 28 millimeters long, and it was ballooned to 4.0 with a 4.0 balloon. So essentially, the stent was almost exactly what we got from the CT. So now HeartFlow has a product which we are using it, but it's not commercially available everywhere yet. And you can have this on your iPad, iPhone. You can go online. You can kind of click, as I'm doing here, on the vessel, on the LED, and it will tell you what the diameter is where you're clicking. So right there, so that tells you the diameter of the vessel at that location, diameter over here. This tells you what the length is. So the length is 10 millimeters. You can simulate what fixing it would look like. And then you can take this information before you go to the cath lab. So this is something that's called PCI planner. It has a virtual stenting. It has a couple of different things. But this can help the interventionalist ahead of time so that, well, one is you use less contrast during the procedure, less radiation, because you don't have to take as many pictures ahead of time. Just by reviewing this, you can know what the stent size will be, where you're going to put that stent, and what's the best view for stent deployment. And again, this is something that you can have available in the cath lab. You can put it on your cell phone, iPad, whatnot. This was an interesting case that we had from about a year ago. This was a 52-year-old man who had some risk factors and had a stress MPI. He had chest pain. And the stress MPI showed a very, very small defect, 3% of the left ventricle. The physicians that was taking care of him decided to get a CT done, and then we did FFRct, and you can see from the CT, here's the LAD, a lot of severe disease here in the mid LAD, in the proximal. You can see that the FFRct becomes positive here at less than 0.5. A lot of disease in the right coronary artery, a lot of disease in the circumflex as well. In the circumflex, FFRct is positive, but the FFRct of the RCA is negative. It's above 0.8. So this patient went to the cath lab and they measured the invasive FFR, which is considered the gold standard in all three vessels. And again, in the LAD, the invasive FFR was positive. It was positive in the circumflex, and it was negative in the right coronary artery. So essentially, this patient went on to get bypass surgery, and the vessels that were identified from the CT and from FFRct were the vessels that were bypassed during surgery. So in a way, I kind of pose this question in that this patient did not necessarily need to undergo a cath. Now we're not there yet, meaning most surgeons and probably interventional cardiologists today would not feel comfortable directly sending a patient to the cath lab, directly sending a patient to bypass in terms of deciding what vessel is going to be bypassed and exactly where. But in the next few years, this is something that we can definitely do without an invasive procedure. And there was a trial that was done in Europe about a year ago where they had two teams. Each team was composed of a surgeon, cardiologist, and an imager. And the teams were kept separate. And the teams reviewed a patient's cath and invasive FFR and then made a decision as to what needs to be done. And then they reviewed the CT and FFRct, and then they made a decision based on that information. And one team saw the cath data first, and one team saw the CT data first. So essentially, between the two teams, there was a 93% concordance, meaning they came to the same decision in that this is the vessel that needs to be bypassed, or this patient needs to have a PCI, or this patient needs to have a bypass. So that was kind of just a very brief sort of and busy overview as to some of the things that we use the FFRct for, and I wanted to use the rest of the time kind of review more so our protocols and especially how this looks from the techs and from the nurses' perspective. So I'll take you guys through everything from epic order goes in to results come in and what we do with them. So currently we use an order set. We use Epic for CTA. So here's a picture of our Epic. We have a couple of different orders for CT. We have a coronary CTA only, and then we have a triple rule out order. In either one, you can order without calcium scoring, or you can order it with calcium scoring. It's completely left up to the physician that wants to order it. That being said, about 90% of our coronary CTs we do without calcium scoring. And we do about 4,500 coronary CTs a year here at Beaumont. And we scan patients every day of the year, so 365 days. And we scan patients 8 a.m. to 7 p.m., with the last read being around 8 p.m. So this is then the expanded kind of order set, what it looks like. These are the options, the CTs you have to pick from. So again, it's essentially just a triple rule out with or without calcium score, and coronary CT with or without calcium score. Whoever orders it has to pick a dose about beta blockers. And the beta blockers are essentially given based on an order set. Typically, it starts with either 50 or 50 or 100, and then based on the heart rate after that. So this is just kind of some directions about what to do with the beta blockers. We have 2 nurses that essentially hang out in the area where the CT is, and they just spend all of their time in ensuring that the patient's heart rate is controlled. This is mostly for outpatients. So when the outpatients come in, they get an IV, they give the first dose of beta blockers, they give additional beta blockers if needed. And then when the patient's ready, they'll go in the CT scan room and they'll give the nitro as well. For the patients that are in the hospital or are in the ER, these two nurses are in communication with the patient's nurse, but these are not the nurses that give the beta blockers. The nurses that give the beta blockers is essentially the patient's own nurse, either the nurse on the floor or the nurse in the ER. Again, for the most part, there's two working. Occasionally, typically at the end of the day, then there might be just one if it's not too busy. Our techs, so currently we have six technologists that are sort of cardiac trained, and they are dedicated to working on that specific scanner. Almost all of our cardiac CTs are done on a Siemens flash. It's a dual source flash scanner. It is not a dedicated cardiac in the sense that if there's a PE only study or an aorta only study, they can happen on that same scanner as well. But all of the cardiacs will happen here. And the techs essentially are the ones that decide what protocol to use most of the time, unless they have a question. Then they call one of us, the readers. The techs are the ones that decide what protocol to use for each patient. And they're the ones that get to review the images and essentially let the patient go, or if there's an artifact, and if there's a significant artifact, then they will repeat the scan. They'll make that decision. But sometimes if there's a questionable artifact, then they'll page one of us readers to review the images real time. Patient is still on the table. And then I make the decision with the tech as to, okay, scan them again and use this different protocol, or yeah, there's a little artifact here, but I can still see the image, let them go. Most of our patients, we use a step and shoot sequence, so prospective scan. We obtain 3 phases. So on the Siemens, those are 65, 70, and 75%. Occasionally, depending on heart rate, depending on rhythm, then we'll do a retrospective scan, and the window will vary, meaning we'll obtain images from like 40% to 80% or 30% to 90%. And that's a decision kind of that's done on a case-by-case basis. Again, this is our most common scan, which is prospective gating. I don't know if you guys use the flash mode very frequent. So Siemens also has this sort of high-pitch spiral called the flash mode that you can do, especially with the dual source. We rarely use this because you're only getting, if you use this, your radiation dose is going to be lower, but you only get one phase, and that's it. And if you have a problem with that phase, then you only get that 60%, and you don't get a 65%, you don't get a 70% to check the images. And if you get a little artifact in, let's say, that mid RCA, then you're basically stuck. So very rarely we'll use this mode. Typically, if an image, if we do the image and it's a young person, let's say, especially if it's a young woman, heart rate is low, but there was a little artifact, patient moved, whatever, we need to repeat the image. And if I'm confident that her heart rate is nice and low, regular in the 50s, then I might say to the tech, okay, just the second time, use it, repeat it on a flash mode, So that way I can keep my radiation dose the lowest. And chances are if there's an artifact that's going to happen with a second time around, hopefully it's not going to be exactly in the same spot as the first time around. So we use Terra Recon to read all of our oral studies, look at the images. Another protocol that we use is something that we call the arrhythmia protocol, and we use this mainly on our AFib patients, where we scan a predetermined time after the R interval. So as you can see on this patient, we'll scan after the R wave, we'll scan 250 to 450 milliseconds. As you know, in patients with AFib, the R to R interval can be pretty irregular, and that can offer a better alternative. So this is just what our Terra Recon looks like. So we look at the images, the reader decides that there's some disease in this patient's LAD or whatever. I want to send this CT off to heart flow. So we send the images directly from heart flow. There's this button here, send, click on that. Once you click on that, this comes up. And then we have three options for research studies. And then we also have regular and stat. So stat is anybody that's inpatient, ER, and the reader does this. So then we send this off to heart flow. And then in Epic, we have to put in an order for FFRct. And in that order, then we have to also say, why are we ordering FFRct? This is kind of our internal guidelines that we're using when to send a study for FFRct evaluation. For the most part is if there is a stenosis of greater than 50%, so between 50 and 70%, or if there is too much calcium that basically prevents you from looking at the lumen. Though by far most fall into those two categories. Then a couple of hours later, we get an email from HeartFlow. And currently our notification system here is that there is an email that goes to the scanner, to the room where the CT is, and the techs have that available. And then the techs are the ones that get that email. And that HeartFlow ID will tell you which case it is. That links up with our MRM. The techs then will notify the readers. So let's say if Elvis is reading, I'm reading right now, they get the results, the techs get the results, and then they'll page me saying the results for these patients are back, dictated in an Epic. And then we go to the HeartFlow website, use your Beaumont email, password, and this is essentially kind of what it looks like, a list of all of our cases. We'll log on to the website, we'll look at the results, and then we'll then addend the results in Epic. Kind of some of the internal policies and guidelines that we're using in selecting the patients who should be sent for FFRct. Essentially, I showed you that table. This is just our internal policy document of that table, which for the most part, we're using it on patients that have a greater than 50% stenosis, or in which patients there is a lot of calcium and you cannot see how bad the stenosis is. For inpatients, we're being a little restrictive because there's an extra cost to sending this. So there's, for patients that are admitted to the hospital, that get a CT, that need FFRct, then there's a internal communication that has to happen first. Reader with the cardiologist that's taking care of the patient. And in general, if there is such a severe stenosis, a greater than 90% stenosis, those we're not gonna send for FFR because those patients are gonna go to the cath lab likely anyway. or in patients that a decision has already been made, that the patient's going to go to the cath lab, then we usually don't send those for FFR as well, because again, there's a cost to this, and then it just becomes wasted. So that was kind of it, just a brief overview of FFRct, what it is, what we use it for, and kind of our protocol in day-to-day, and what we do with it.
That's great. That's great. Thank you, Elvis. There's a lot of information packed into a short period of time.
Yeah, we can spend a whole day talking about this.
We certainly can. Can I ask a couple of questions before we let other people answer?
Yeah, of course.
So one is, one of the biggest problems with coronary CT that's been criticized over the last 15 years is that calcium lowers our ability to tell what's going on in the patient. So a couple of questions about calcium. Does the calcified vessels also reduce the accuracy of the FFRct?
Yeah, and the short answer is yes, it does. So as you can imagine, because they have to see the lumen, right? I mean, when they model, when you send them the data set to HeartFlow, they have to model the lumen of the artery. So they still have to do that. And it can. There was a paper that was published by Bjarne Nørgaard, who's written a lot of research in CT. And he compared arteries that had calcium with arteries that did not have calcium, and how the accuracy compared on FFRct, and it was a little bit lower, but the difference is very small.
Okay.
We're talking about like 88% accuracy versus 85%. I'm just making those numbers. There was like a 3% difference.
Okay, so it's minor. So there's still a lot of value in this. So,
yes.
so do you feel like this is opening up coronary CT to a lot of calcified patients that
Absolutely. And we scan here 70-year-olds, we scan 80-year-olds with diabetes, with hypertension, very, very routinely. And without FFRct, I wouldn't be able to tell. I mean, I can't tell if I just see calcium, I can't tell how bad that stenosis is.
Yeah.
If you have FFRct, all of these patients would go to the cath lab because you just can't tell.
Right. So for the last decade, I've told our technologists to do a non-contrast exam before we scan to review the degree of calcium, and if it's horrendous, to stop. Sounds like because you guys have FFRct, you go ahead because you have this additional tool to get through that. That's smart. Now, when you do the non-contrast CT, just in general, do you actually score it, or do your techs just eyeball the location and say, well, the left main is calcified or not?
No, we score it.
You do actually create a score. Okay.
Correct. And and the reason for that is that's because how it was ordered. So one of our orders says with calcium scoring, and if that's what the provider picked, then we do score it. But the scoring is done almost automatic. The techs do it actually.
Okay.
And it's done on the machine. It's fairly automatic. And then I just put the number in. But on the few that are done with calcium score, and sometimes the calcium score will be like 2,000, and the tech will call me and say, hey, the score is 2,000. Do you want to do the CT or not? 100% of the time, we'll do the CT.
Okay, so you're not using that to actually stop the exam. Okay.
Correct.
And what percentage of the patients that you're scanning are triple rule outs, and what percent are straightforward coronary CT in terms of the orders at your hospital?
Yeah, probably about 15% are triple rule outs.
Okay.
Maybe 15 to 20%.
Okay.
For the most part, the triple rule outs are from the ER, but sometimes there's outpatient triple rule outs too.
Oh, really?
Yeah.
That would not be something I would guess. Okay. And then in terms of AFib, for 10 years, I have told our techs send AFib home, but could you talk a little bit about that? Because now that you're getting good results in AFib, you have the technologists reconstruct. Your range on the Terra Recon was 250 to 500 milliseconds.
Yes.
How do you decide, or is there just a number that you pick to reconstruct.
That's the number that we came up with for our protocol, that 250 to 450. This arrhythmia protocol, meaning where we will scan after the R wave 250 to 450. Now, sometimes me as the reader, I'm not a fan of that protocol that much. It's not bad, it's good, but sometimes what I'll do is a retrospective study instead, and then use a window of like 30% to 90%, meaning so current is up all the way 30 to 90%, and then between 90% and 30%, then we turn the current down to save on radiation. So we use min dose outside of that window. In the past, what we used to do was we used to do a flash study on all of our pulmonary veins. So meaning pre-AFib ablation, our EP guys get a pulmonary vein CT, and we used to flash those patients. And that way it was easy, it was quick, and radiation dose wasn't that high. But we also we do a full coronary read on those patients, and those patients get nitro as well. And then we started to use FFRct, and we noticed that a lot of those, if you flash them, you would have an artifact, like the RCA would be motiony, it would be blurry, and then these patients would have disease, and then we couldn't send it for FFR because the study was not good quality. So we stopped actually doing the flash on those patients. So now those patients either get a prospective scan or a retrospective scan so that we can do a full coronary read and be able to send it for FFR too.
Okay. And how long is it taking on average for the FFRct result to come back to the docs?
So we have two pathways at Beaumont. We have an ER pathway. So anybody that comes from the ER or people that are hospitalized in the hospital, we send them through the ER pathway, and that comes back in 2 to 3 hours.
Okay.
And for anybody else, if it's a routine outpatient scan, we'll send it as a routine, and that will come back in like 6 to 8 hours.
Okay. 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 Well, anybody have any questions for Elvis? From a technologist standpoint, from a nursing standpoint?
I do here at Norfolk General.
Please.
So what is the normal doses of contrast that you give the patients? And if you repeat, what's that dose of contrast?
Yeah. We probably give more than we should. Yeah. So our coronary CTs, essentially the lowest dose that we'll give is 80. But it's mainly dependent on BMI. The highest dose is 120. So 80 to 120, depending on what your BMI is. If your BMI is like 45, because we don't have a BMI cutoff, you know, if your BMI is 45, we'll scan you. If your BMI is 50, we'll scan you. And those patients get, again, 120. If we need to repeat it and the BMI is high, then it gets a little tricky, because if you gave 120 the first time and then you give 120 the second time, that's a lot of contrast. Up until about a year ago, we had a policy of the maximum dose the patients can get is 200. So then if we needed to repeat it, we had to stay within that 200. And radiology changed that policy late, about 6 months ago. So now that maximum dose is like 250. So if we need to repeat it, essentially it'll be about the same. So let's say if your BMI is like a 37 and we gave you 100, and we need to repeat it the second time around, it's probably still going to be 100. For our TAVRs, we use 60, and for the TAVRs we use a little bit less because these patients are older. A lot of them have kidney disease. And even though we try to read the coronaries on all of our TAVRs, that's not a requirement. It's not a must. So for the most part, we just need to be able to look at the annulus, look at the aortic valve, and the bigger structures, you can get away with a little bit less contrast.
Elvis, for our nurses, can you talk about your beta blockade protocol? Because I know you guys push doses even higher than we do.
Yeah. So we use essentially just metoprolol, IV and PO. If that's not enough, then our second go-to as of a few months ago is Corlinor or Ibrabadine. Rarely it's used though. Our typical doses for beta blockers is up to 300 oral and around 30 IV.
Will you give 300 at one time?
No, it's usually given in increments of 100.
Okay, so 100, then wait 30 minutes, then another 100?
Yeah, wait about 30 to 45 minutes, then give another 100, wait another 30 to 45 minutes or maybe an hour, get another 100, and then IV if needed also.
Okay.
The problem with Corlinor is cost, because it costs more than beta blockers. So people are not excited about giving it, but I have used it a couple of times. And we do not make our ordering physicians give beta blockers when they order the study as an outpatient. So like if Dr. Basine sees a patient in clinic and needs to get a coronary CT, he just orders a coronary CT. We do not make him give the patient a prescription for beta blockers to take. The nurses will deal with that when the patient comes in, because that way it makes it a little bit easier. If you make it more difficult for physicians to order this study, and now they say, well, I gotta now order medications in addition to the test, it becomes a little bit more. It becomes a little bit more challenging.
It's more challenging. That's right. Anybody else?
I have a question about flow rate for contrast. What is your average flow rate for patients that you anticipate FFR? Like
Yeah,
CT per second? Six on average, and that's a 20 or an 18?
So we'll try to get the biggest IV that we can. So 18 is ideal, but sometimes a 20, if all they can get is a 20, then essentially that's all you get.
Do you change your flow rate based on BMI?
For the most part, no.
Okay.
We use the 6.
Great. Okay, well, that's 8:15. I think that was great. Elvis, thank you very much. If nobody has any other questions, we're going to sign off. I hope everybody has a good work day, and we will see you all again in 4 weeks.
Thank you.
Thank you.
Have a good day, everybody.
You too.
Yes.